Welcome to Call the Doctor. We are delighted that you joined us this evening, and I am not Dr. Mark Perlmutter. He is not with us tonight, but he wanted us to go ahead because we have just fabulous information tonight. And we've got, as our physician, we've got Dr. Akshay Sridhar,
That's right.
a urologist.
Thank you for having me.
Oh, thank you for coming. And folks, urology, I mean, we're going to be talking about kidney stones, we're going to be talking about prostates, we're going to be talking about getting up frequently to go to the bathroom at night and what can be done about it. I mean, lots of great tips. So, and also Dr. Mary Strickland, Vice President of Nursing at Nash UNC Hospital or Healthcare. So thank you.
Well, thank you. Thank you for having me tonight.
Oh, you are so welcome. Let's start with, you have been at UNC Physician Network in Urology. How long have you been here?
So I've been here since August of last year, so August of 2021. I started, I believe, August 4th, if I'm not mistaken. So it's been approximately, 10 months now?
Great.
But it's been fantastic down here. Yeah.
It's a busy area for your practice, isn't it?
Very busy. Just this past month, it has significantly picked up, both for just myself and my two other partners.
Well, and there are three, and y'all are going to add another one too, right?
That's
this
right,
summer?
yeah. So currently we have myself, of course. We have Dr. Matt Pazak, who I call he's a Rocky Mountain native, so he's the star of Rocky Mountain.
Oh, good.
Yeah. And we have Dr. A.C. Afiadata. He joined last year, and we'll be getting Dr. Cowder. He's coming in from Dartmouth.
Oh, good.
Yeah.
Where did you grow up, and why did you decide to go to medical school, and why urology in particular?
Yeah, great question. So I actually was born in India.
Uh-huh.
So I was born in India, and I lived in Bangalore, which is a large city in southern India. I lived there until I was 6, and my father got a position in Queens, New York. And so initially he moved there, and my mom and I moved there as well. Lived there for a few years, and then we moved to Plainsboro, New Jersey, and it's exactly as it sounds. It's very plain. There's nothing too exciting about it, except that we were near Princeton, which is a very cute little town. So I grew up there, and then I went to Rutgers University in New Jersey, which is a state university of New Jersey. I studied actually engineering, so my path to medicine is not direct. It's more of a circuitous route. And so I did biomedical engineering, and then I ended up doing my master's in that as well. Then I worked in industry for about a year, and during that time period, one of my friends had applied to medical school and said, hey, you should check this out. And so I applied, I got in, and the rest is history.
Wow.
Must be really smart to just get in like that, right?
It was a lot of
awesome.
it was a lot of time. But yeah, so I went to medical school, and same thing. Everything I say is just, it was because of my friends, right? So my friend ended up going into urology. I originally wanted to become a cardiologist, just like all the other Indian people. And he said, try urology. So I did. I did it for one day. And I said, oh, this seems like a pretty good career. And he said, well, if you're going to do it, just do it. And I did it, and then I got in. That's how it happened.
Well, I would think that that engineering background with all the technical things that are utilized in the urology field, that probably has really helped you a lot.
Absolutely. I think being an engineer lends itself to being a surgeon, really. Really just working with your hands. Same thing with orthopedic surgery as well, because we did a lot of prosthetic devices. But yeah, it certainly did help with my hands in the operating room and just how devices worked.
I had met a nurse before that had an engineering degree, and just to hear this individual talk about how it helped him in the clinical arena and using the technology and the equipment, so that just kind of made me think of that.
Absolutely, yeah. I think it's a huge help when you come from that kind of background. I think it lends itself to really doing whatever you want. You know, whether or not you want to go into finance, medicine. For me, it just happened to be medicine.
It's perfect.
Yeah.
A lot of people think in terms of your field being more for men, but you see women too, don't you?
Absolutely. So 50% of our patients are women, and the reason being, women have kidneys too.
That's exactly right.
Women have kidneys and bladders. And so, yeah, they have the same, kidney stones, bladder issues where they have frequency of urination, urgency of urination, UTIs, all of the things that occur to men with respect to those organs, the kidneys and the bladder, happen to women as well.
Well, and one of the things we want to do on this show is to tell about different things in the treatments for them, because there are a lot of people who are suffering with conditions and they don't know there's help for it.
Absolutely, yeah. That's one thing I always tell my patients when they come into the office. A lot of my older patients say, hey doc, it's just, I say, how is your stream? For example, for men, how's your stream? Well, it is what it is for a 75-year-old. I said, well, it doesn't have to be. There's things that we can do to help you, and there's no reason for you to suffer and have this current quality of life when we can have non-invasive or minimally invasive or non-invasive measures to help you improve your quality of life. And we're in the business of improving quality of life.
Absolutely. Well, we've got a whole bunch of, why don't we start with, first of all, cancer.
Sure.
Well, let's, with cancer treatment of kidney, prostate, or bladder.
Yeah.
How's that diagnosed, and what do you do for it?
Sure thing. So let's first start with prostate cancer.
Okay.
Because we start screening for prostate cancer generally around 55, at least that's what the guidelines state. And so what does that mean? So prostate cancer is basically, if you just look at this diagram here, or rather this model.
And let's see if we can zoom in on that. If you'll just kind of hold it there, we'll see if we can. Okay, Lee, can you zoom in on this? There we go.
There we go, perfect.
Okay.
Okay, so I'm going to hold that up right there.
Yeah, good.
There you go. Okay, so the prostate gland is right here, and in men it's attached to the bladder, right? So the urine flows from the bladder through the prostate and then out through the penis. So prostate cancer occurs right here. This is where the prostate gland is located. So generally, as men turn 55, we start screening for prostate cancer, much like we screen for colon cancer. And we generally do that with blood work, something called a PSA. So we get that from the blood. And that tells us whether that level is elevated or not elevated, right? So if it's elevated, we generally like to explore that more. We also do a rectal exam where we put the finger in the rectum and feel the prostate. Feel for really any bumps, any irregularities. Make sure that it's smooth. If it's not smooth, that's more cause for concern.
Would an increase in size be a cause for concern?
Yeah, absolutely. Specifically, when you're doing a rectal exam, you're looking more for irregular shape and size. Size you can't accurately determine size. You can just do it based off of feel. But in order to accurately measure the size of a prostate, you would need some kind of imaging, transrectal ultrasound or something.
Right.
But generally, that's what we do for prostate cancer. We screen. So I also tell my patients in the office when I do diagnose them with prostate cancer that one thing, it is not a death sentence. Again, I do want to repeat, it is not a death sentence. It's very treatable. So to your question, how do we diagnose prostate cancer? I generally get referrals after they've been screened by their primary care physician. So their primary care physician gets the PSA and they do a digital rectal exam. When it's elevated, I get the consult. So they come and see me in the office. And I generally like to repeat the PSA just because you can't go based off of one number. You want to reproduce that number. And if it's on the upward trend or if it's still persistently elevated, then I talk to the patients about, okay, well, it's still elevated, and one of the reasons it could be elevated is you might have prostate cancer. This is one of the things we want to make sure that you don't have. The only way to really do that is through a biopsy. And so we generally do that in the office. And so what we do is we have them come to the office the day of the biopsy. They lie on their side, and I initially just feel the prostate. After that, we put a rectal probe in there, and I see the prostate actually on my screen. And so I can visualize the prostate, see if there's any irregularities there, if there's any masses or dark spots on the ultrasound. After that, we just numb up the prostate. So I tell them after that, you really should feel no pressure. That injection that's going in for the numbing medication, I liken it to when they go to the dentist, because everyone's been to the dentist, right? But not everyone's had an ultrasound-guided biopsy. So I say it's generally when you get a injection in your gums, it's kind of what it feels like, except it's down there. All right, so that's the difference. And after that, they generally don't feel any pain, just pressure, just much like at the dentist. And we take 12 samples, 6 from each side of the prostate, and then we send it for analysis. I see them generally 2 weeks afterwards, and we go over the pathology results. So let's say someone has prostate cancer. It comes back as, certain spots lit up on the biopsy. Well, prostate cancer is not all created equally. So generally, it's stratified into different categories of risk. So there's a very low risk, intermediate risk, high risk, and very high risk. depending on where they fall into, I come up with a plan specifically for them. So some of the low risk and very low risk categories, you actually can just watch it. We watch it by just getting the PSA every 6 months, and we do, as much as they don't like to hear this, we do a biopsy every year. And so that way we can keep a very close eye on it, and it allows them to maintain their current quality of life without undergoing too many changes. That's, again, that's only for the low risk, very low risk, and one of the intermediate categories. Now let's say that that's just not an option for them, depending on where they fall into, if they're high risk or very high risk. Well, at that point we have, at our practice, we have generally 2 options. We have surgery and we have radiation with a plus or minus a hormone treatment. So the surgery, actually, my partners, Dr. Afiadata and Dr. Pazak, perform robotic-assisted prostatectomy. That's a big word. That's a bunch of words. It's a mouthful. So essentially, what does that mean? That means we make some small incisions in the belly, and we go in there with a robot. We actually remove the prostate. We remove the prostate in addition to some lymph nodes to make sure it hasn't spread. We do that, and then basically what we do is we remove the prostate here, and we reconnect the bladder, the opening, to the rest of the urethra, which is the tube that you pee out of. And after that, we generally put a Foley in and Foley catheter in, which I'll go over a little bit later, which is just a tube that drains the bladder. And we see them generally 10 days after we remove it. That is meant to be a curative procedure because you're getting rid of the gland or the organ that has the cancer. But just because we remove it doesn't mean that we're home free. We have to monitor them for the rest of their life, right? By getting a PSA to make sure it's not elevated. So that's prostate cancer. Do you guys have any questions?
I do. Well, you go ahead.
I was just going to say, would you recommend, like, if there's a gentleman that would be positive for this or be diagnosed with this, would their children need to be concerned? Is there some type of, is there often genetic relationships with prostate cancer?
That's a great question. And yes, there is a genetic link with prostate cancer. If you see it a lot within the family, and you gather that when you're seeing them for the first time, you always ask them, hey, does your father or anybody in your family have prostate cancer? If there's a strong link, there's actually genetic testing, germline testing that you can do to check to see if they have that particular gene. Yeah, generally we do that with, oncology will determine whether or not they need that. Yeah.
I have a really good friend whom I just found out has stage 4 prostate cancer.
Okay.
If a person gets checked frequently, like every year, can that be avoided, or what do people need to do to be sure they never get in that condition?
Yeah, so that's precisely why we recommend and advocate for early screening. If we get you early at 55 and we start screening you every year and you're consistent with going to your primary care physician and getting screened, you're unlikely to enter that scenario.
So you're saying if people watching every year starting at 55, it's important to get it, because if so, it can be caught early, or probably caught early. But as I hear, as men get older, the reason we're hearing more about it is because we're living longer.
Yeah.
And that it's something that as one's immune system gets weaker, as one gets older, that more people have prostate cancer.
Absolutely, yeah. And the thing about prostate cancer that is good for it is that it's actually a very slow growing cancer. While a lot of men in this country are diagnosed with prostate cancer, it's not necessarily, if you follow it closely, not what ultimately kills them. It is a slow growing cancer, so that's why it's so early, it's so important rather to catch it early. And that way we can treat it.
So we need the women to tell their husbands to be sure and do it, because if they don't or their primary doesn't, it's crucial. I mean, it makes all the difference if it's called early.
It really does. It really does. And you catch it early, you start treating it if need be early, and you just maintain your quality of life, and you generally live longer, right? Don't we all want to live longer?
That's exactly right.
Yeah.
You want to talk about kidney and bladder cancer. How do people suspect somebody has one of those?
Yeah, so kidney cancer is generally found what we call incidentally, which means they go to the ER, or their primary care physician or another physician just orders a CAT scan or an ultrasound, a renal ultrasound, kidney ultrasound, for whatever reasons that they're looking for. They're not looking for anything kidney related, they're just looking for something. Perhaps it's GI related, related to your guts. and they find an incidental mass. They find a mass on the kidney. This patient was completely asymptomatic. They didn't have any blood in the urine, they didn't have any belly pain, they didn't have any back pain. It just was found on imaging. That's how most masses these days are found. In the olden days, it used to be that they wouldn't get this many imaging, right? They wouldn't get CAT scans on everybody. And so because of that, these masses were growing and growing to the point where they started seeing blood in the urine, or they were having a mass you can actually feel through the belly or the back. And so those tended to be a lot larger. But these days we're finding smaller masses, incidentally, overall on average, of course. And the way those are treated, depending on the size and the location of the mass, you don't necessarily have to remove the entire kidney. You can just remove a part of the kidney where the mass is located. And that's called a partial, which means only a part of it, nephrectomy, which means removal of all or portion of the kidney. And essentially what we're advocating for is kidney sparing surgery, right? If you can do it, we will do it. And it's a lot of times small renal kidney masses, kidney tumors, generally that's under 4 centimeters, we can watch it. You know, that's something that you surveil. I mean, you don't necessarily have to operate on it. It really depends upon the patient. You know, a lot of patients, when they learn that they have a mass on their kidney, they just want it out. They don't want to live with it. They say, "Doc, you know, there's cancer in me. Get it out. It's too much. It's causing me too much stress." And that's another thing you can do with the robot. And in fact, Dr. A.C. Afidata and I just did one today.
Wow.
Yeah, yeah, it went really well.
That Da Vinci robot is really
it's wonderful.
great that we have it at our hospital, isn't it?
Can you imagine you can do major surgery with tiny incisions? I mean, isn't that insane?
We've come a long way for sure.
We really have.
Technology.
Absolutely.
And we had Dr. Warnsby on, and she talked about it a little bit. But for people who didn't hear her, you can do it and see on a big screen. Kind of describe what it's like.
Sure. So when we do surgery with the robot, the Da Vinci robot, you make small incisions in the belly, and you put these things called ports, which are basically access or entryways into the inside the belly. And then you have arms of the robot, which connect to these entryways. And then you could put different kinds of instruments. You know, you can put scissors, you could put different kind of graspers, all of that. And so when you put that in there and you're looking at it, so you have the robot here, right? You have the robot here, and you have the patient right next to the robot, and because it's connected to the ports. And then away from the robot is actually where the surgeon's located, which is just mind-blowing if you really think about it, right? And he or she is sitting at the console, which is where basically it's like a video game. You're looking inside, and you can actually see everything inside the belly that you're pointing the camera at, and it's actually in 3D. So you have depth perception as well. And so as you're doing that, you have ability for micro movements. And so ability that you wouldn't necessarily have with open surgery, where we make a larger incision, and we may not see these really tiny vessels that are bleeding. You can see all of that in the robot.
Wow.
Yeah.
And I think, too, the healing time post-operatively is huge, you know, for the patients following a robotic surgery versus a full open procedure.
That's right. So, for example, since we're talking about prostate cancer, so generally, the olden days, they used to actually make a large incision at the bottom of the belly and take the prostate out. There was a lot of bleeding associated with that procedure, bleeding that required blood transfusions during the procedure. But now, with the robot, essentially it pumps this air that's inert, that's not flammable, into the belly to make it big so we can see. And that in itself actually just stops the bleeding.
That's right.
Right? And so after we do the procedure, there's actually very little blood loss during the procedure. And they go home the next day. There's people, Dr. Afidata recently has been sending his prostates home the same day, which is incredible, which would have never happened before.
Right.
Yeah. Let's take a break, and we come back, we're going to talk about kidney stones.
Sure.
You've got advice for people who, if they've had them, they don't want to have them again.
You don't want a kidney stone.
No. Mary's had one.
No, you don't.
No.
And also the UroLift, which helps frequent nighttime urination. There's something to be done about that, isn't there?
Yeah, we'll definitely talk about that. We can go into detail.
We'll be
great.
right back.
Thank you.
Yeah.
The foundation plays a really integral part in the health of our community. They help with the health system identify those needs and gaps.
As a physician here at the hospital, we utilize the foundation to offer a lot of supplemental support services that may not be covered by insurance, but are fundamental and instrumental to the health of our patients.
The foundation may be able to assist with some of the financial burden that the patients experience outside of the hospital, such as rent assistance, utilities, and some medication needs.
The inpatient food pantry. The foundation has been instrumental in raising money here, and it's meeting a critical need that many of us don't know about.
Getting them the food and the help that they need, especially from the food bank that we've implemented, has been really successful, and our staff have been really engaged and excited about being able to provide this service to the community.
Their support of our cancer center and services, the heart center, the women's center, hospice.
There's everything from getting car seats to, at the same time, we needed a new ultrasound machine, a significant contribution that makes us be able to just quickly bedside do an ultrasound. And in some cases, not too recently, I walked into the room, never met the woman, scanned her, and said, okay, we're going immediately to the operating room and you're going to have a baby. It was life-saving for her baby.
When patients are having difficulty getting home, maybe they came into the emergency department on an ambulance, and the Foundation's Patient Assistance Fund will sometimes help get them to their home.
We had a patient who had diabetes, and he needed help getting a machine to check his blood sugar levels and all of the supplies that he needed to do that. I reached out to the foundation to see if they could assist us with providing that to the patient, and they were able to do that for him.
The new community paramedic program is an outreach to help folks who are being discharged from the hospital, making sure they have what they need and are set up for home.
And the foundation allowed us to go from 1 community paramedic to 3 community paramedics.
People don't realize how many extra services people need that aren't covered by insurance or are not included as part of healthcare, but have such a tremendous impact on health.
And the foundation and all the positives that they do in the community, the different ways they serve and work together and serve the community. It's easy to get behind it more and more and support it.
Because we all live in the community and we all want a healthy place to live and work.
It's so important that the community continue to support the foundation, mostly because of how closely we at NASH work with the foundation. We're able to go and say, hey, this is what this patient really needs, and we're able to provide that assistance.
It's my sense of loyalty to this community and the citizens that makes me want everyone to have good health care.
And I could not agree more. I think we all have a bit of a duty to try to have good health care for everyone, and this is a way that we can do our small part to do that.
Welcome back, and we want to thank our sponsor, Carolina Regional Orthopedics, Dr. Mark Perlmutter, as you've seen on here, who's absolutely wonderful, was unable to be here tonight. We've got Dr. Sridhar and, Dr. Mary Strickland.
Thank you.
And we want to jump right into kidney stones. You've got so much information, and this is an area that has lots of kidney stones, right?
Yeah, it's the, they call it the kidney stone belt.
That's right.
You know, much like the Bible belt, it's the kidney stone belt. Yeah, generally people, if in drier areas, people, are you okay?
I swallowed something the wrong way, yeah.
Okay, no worries.
I'm good, thank you.
Sure. So generally in drier, warmer areas, kidney stones are more prevalent, right? But kidney stone, I'm from New Jersey, and that's not always a warm area, clearly, right? It has all 5 seasons. But even there, you'd be surprised at how many people have kidney stones. And the #1 cause, the most common cause of kidney stone formation, dehydration.
Oh,
we are not drinking enough water. Right.
Got to do better, don't we?
What's enough, though? How do you know if you're drinking enough?
You generally want to consume approximately, this is a lot, but about 2 liters. They want you to produce about enough water to produce about 2 liters of urine.
To keep yourself
well hydrated.
hydrated.
So what I generally recommend to my patients that have kidney stones, which are a lot of them, I tell them, you know, they make these big jugs that you could put water in, and they have times actually on the jugs. The only thing you have to carry the jug. That's the thing with this. But you know, you're working, you're busy, you're on the computer doing whatever you're doing. You look at your jug because it's right there, and you say, hey, it says 9 a.m., and it's 9 a.m., but my water level's at 8 a.m. Oh, let me drink this much. So it'll keep you on task to drink that water. But that is the #1 reason for kidney stone formation. The most common type of kidney stone is called calcium oxalate. This is basically made out of calcium. Oxalate is in tea, which everyone in the South loves to drink, is what I've learned after moving down here.
Sweet tea, especially.
Sweet tea, exactly,
That's right.
exactly. And so tea has a lot of oxalate in it, and green foods have oxalate, and you know, spinach, things like that. Everything in moderation. Everything in moderation. I would never restrict anyone from saying, don't ever drink this, don't ever eat that. That's fine. Every now and then you can eat that, you can drink that, but just be conscious of how much of it you're consuming, you know. And so same thing with sodas. I tell them to stay away from sodas. People down here also love sodas. There's one soda that I heard of, I'd never heard of before. What's it called?
Sundrop.
Sundrop.
My husband's favorite soda.
Sundrop. Everyone's talking about Sundrop. I'm like, I have no idea what you're talking about. But it's some kind of soda, isn't it?
So
Right?
any soda's not good from that
Yeah,
perspective.
exactly. And not only just for kidney stones, just generally speaking. It's what it does is it actually makes you more dehydrated.
That's right, it affects your dehydration.
Okay.
It makes you more dehydrated. And a lot of these sodas have caffeine, right? And so caffeine is also, just a little aside, it's an irritant to your bladder. So drinking a lot of soda, you're going to want to urinate more because it irritates the bladder.
So you won't you'll be pulling the moisture out of your body.
Right.
Instead of keeping it there.
Exactly.
What are the different ways to treat kidney stones?
Yep, so that's a great question. So kidney stones, well, why don't we go over the anatomy first so that the audience understands what's going on.
Super.
So you have let's say the bladder's right here, so let's just keep it there.
Okay.
Kidney is up here. The kidney is connected to the bladder by a tube called the ureter. That's what drains the urine that the kidney makes into the bladder. Unfortunately for some people, including Mary, kidney stones. The kidney forms kidney stones, right? And these stones, these pesky little stones, sometimes get stuck in that tube. And that's what causes tremendous amounts of pain. And so what happens is this is all just irrigation. So if you think about it, urine flows from here to here. So if you have a blockage here, the urine's going to build up here, and then your kidney's going to get swollen and potentially injured if it stays. And you'll know. I mean, you will definitely know. You will have pain.
You didn't wonder if you had a kidney stone.
I knew immediately.
Exactly. There is no question about it. So generally with kidney stone pain for the audience, you will experience pain in the back, and sometimes that pain wraps from the back to the front. And that's when you know it's generally kidney stone pain. Sometimes for men, you can actually have testicular pain, and that also manifests as that. So just be wary of those things. So anyways, when a stone gets stuck, depending on the size, there's various modes of treatment. So the most conservative treatment is called medical expulsive therapy. What does that mean? That means that it's a size that's passable, generally under 5 millimeters, 5 millimeters or below. So I want you to drink lots of water. I give you a medication called tamsulosin, Flomax is the brand name, that basically relaxes the tube where the stone is stuck. And then you drink lots of water, so you flush that stone. Basically, you're trying to push that stone out into the bladder so that you can pee it out later.
A lot of people say drinking lemonade helps. Would you agree with that, or is that just an old wives' tale?
I think that would be more of an old wives' tale.
Okay.
Yeah, water is the best
Water's
thing to drink.
the best,
Water's
okay.
the best thing to drink, yeah. So that's one way of treating it, and that's the most conservative way. Because a lot of people don't want surgery. But unfortunately, some people need surgery, right, depending on the size of the stone. So they say if your stone, if you look at the studies, 5 millimeters and below, you generally have a greater than 80% chance of passing it on your own. And that's the conservative approach. And that's okay as long as the urine that they gave us does not appear infected. So that's the caveat with that. If the urine is infected, I'm more inclined to offer a procedure. And the reason being, when you have an infection or infected urine that gets backed up behind the stone, that can turn bad very quickly. And so that's something called sepsis, right? I'm sure the
Ooh,
audience have heard
very
of sepsis.
bad.
Yes.
Very bad.
Yeah.
And sometimes
It kills you. It can kill-
it can, that's exactly right.
Yeah.
It can kill you very quickly, and that's why it's so dangerous. Whenever I get a call, if I'm on call, from the ER, and they tell me, hey, I have a guy here or a gal here with a stone, but they have a 100.4 degree Fahrenheit temperature, I'm calling the operating room in right now. Even, I don't care what time of day it is, I'm calling them in, because that can go south very quickly. And so that's something that I want the audience to be aware
Definitely.
of. Okay, so if you ever feel like you have a kidney stone and you spike a fever, I need you guys to go to the ER immediately. And they will call one of us and we will be there to help you. All right, so that's one way of treating it, medical expulsive therapy. 2, there's something called shockwave therapy. So essentially what that is depending on where the stone's located, that really works well if the stone is in your kidney and if it's a certain size. If it's too big, there's going to be too many fragments and it may not work as well. And it also depends on the density of the stone. But essentially what that is you get an x-ray and you see the stone on the x-ray. You can see it on it, because you need to be able to see the stone on the x-ray in order to focus the shockwave beams on it. And it's exactly what it sounds like. You get put to sleep, light sedation, and then the truck rolls by. You get in this truck that has this machine, and this machine has a little gel pad, and then they put shock waves to your body, trying breaking up the stone. And it works relatively well. The only thing is you have to pass the stones on your own.
Is that the same thing as lithotripsy?
That's right, yeah. So there's different types of lithotripsy. This is shockwave lithotripsy.
Okay.
Yeah.
And
So-
we've got a
We have a
van
truck
that comes, a truck
that comes.
Yeah.
Yes, ma'am.
Dr.
Okay.
Pazak is a big advocate. He does most of our shockwave lithotripsies.
And do people have to spend the night at the hospital when that happens, or they can go home?
They go home.
They go home,
Oh,
yeah.
good.
So it's a same day
It's an outpatient.
procedure. That's right. It's an outpatient procedure. They come in, we get them set up, we put them to sleep, break up the stone, they go home.
I want to talk about people because, we're all into helping everybody watching in our area to have
Yeah.
a better quality of life. People who get up constantly in the night to go to the bathroom to urinate.
Yeah.
Is there help for that?
Oh, absolutely. So for men, that's mostly due to their enlarged prostate. So once again, I want to focus on this model over here. So again, you have the prostate here, you have the bladder here. Like I said, the urine flows from the bladder through the prostate and out through the penis. And so when you have obstruction right here at this level, you have extra tissue, prostate tissue, causing the blockage of urine flow from the bladder to the rest of the penis. When you have that, that's what causes that urgency, the frequency, the weak stream, getting up 3 or 4 times a night. All of those symptoms are caused by an enlarged prostate.
Because you're not sufficiently emptying your bladder when you go?
That's right. The
Okay.
bladder has to work that much harder to push urine through a much smaller hole. And so because of that, that's why they experience the urgency and frequency. Also, because the bladder is working that much harder, the bladder is a muscle, much like any other muscle in your body, it tends to get really thick, right? If you do a lot of bicep curls, your bicep will get big. So if your bladder is squeezing really hard on a regular basis, your bladder wall will get really thick as well. But the difference is you want your biceps to be thick, you don't want your bladder to be too thick, because if your bladder becomes too thick, then it will stop working. And if it stops working, then you have to wear a Foley catheter. Which
And that's a Foley catheter?
Yeah, so this is a Foley catheter. And this is used in anybody that are unable to urinate on their own, and they're building up urine inside their bladder, making them very uncomfortable.
And a person could conceivably have to keep one of those in all the time?
Yes, depending on the patient and depending on what condition they have. This is generally meant to be a temporary thing until they get better and we resolve whatever issue that they have.
Oh, good.
So this is a Foley catheter right here, and this is a tube that goes directly into the tube that you pee out of, the urethra. This is used in both men and women. And so here you can see at the end here, this is actually the tip that goes into the bladder, and there's a balloon here at the end, and that's how it stays inside the bladder.
You
So-
inflate that balloon?
Yep, exactly.
Now, women don't have the prostate squeezing on things, but do women have also the similar frequency of urinating, and you can treat them too?
They can, yes. So for women, it's a different issue. as long as they don't have any narrowing of their urethra. A lot of times women have overactive bladders. That's what we call it.
Oh.
And it's exactly as it sounds. It's because it's always contracting and causing that frequency and urgency symptoms. There's medications that we give to calm the bladder down. And that could be after they have a hysterectomy. They could be after they have a C-section, because the nerves run right in that area. So even if any of those nerves get disrupted, it can cause these problems.
But there's help. We need
Absolutely.
that's the takeaway.
There's help. You come and see us in the office. There's medications that we can offer that can help calm your bladder down. And ultimately, if none of those medications work, there are surgeries that we can offer that can help your bladder calm down. So we've all heard of Botox, right?
That's right.
So we're all used to seeing Botox in the face, right? For our wrinkles and so on and so forth. But you can also put Botox in the bladder.
How about that?
Yeah, it only takes about 10 minutes. We do it in the operating room, just like the shockwave lithotripsy. This too is an outpatient procedure. So you come in the operating room, we put you to sleep, we go into your bladder, and then the back wall of the bladder here, we just inject the Botox in the back wall in little grid-like fashion. And after that, the urgency and frequency get dramatically better if none of the medications are working.
Now, for some women, sometimes their bladder may dip down a little, or they have a little prolapse for whatever reason, childbirth or different things.
Sure.
Is that something that you work with in the office as well? Or?
Yes, so we see a lot of the prolapses. Currently, what we're doing is we're managing it conservatively, but there are procedures that you can do to help reduce the prolapse. And there's, Dr. Cowder that's coming in. He does some female procedures, such as urethral slings, which basically help prevent you from leaking, help support the base. He does those procedures, but currently we're looking to get more into that.
Okay, very good.
We've got a video that's a Urolift video. Would you like us to show that, and then you can comment on that?
Yeah, absolutely. You can show that. It's just an ad for the Urolift, but yes, please.
Okay. Lee, if you would play, I think it's about 90 seconds worth of a Urolift ad.
Do you have frequent nighttime urination? An urgent need to go? Weak flow? Do you suffer from an enlarged prostate that blocks your flow? Frustrated with medications? Want to avoid traditional surgeries? How? The Urolift system, a minimally invasive treatment that can improve your flow with no cutting and can be performed in your doctor's office. Call to find out if Urolift is the right solution for you. Imagine an outpatient procedure with rapid symptom relief, done in about an hour, all while preserving sexual function. Common side effects are mild to moderate and typically resolve in 2 to 4 weeks. Results may vary. Urolift is covered by Medicare and all major private insurers. If you want a solution for symptoms like frequent urination, call 847-701-4890 and find out if the Urolift system is right for you.
And is that procedure offered here?
Yeah, we're actually starting to offer it. We're trialing it this month, and I think it's going to go well, and so we're going to offer that. So what is the difference? You saw that it's a alternative to traditional surgeries. So generally, if you go from the start, man comes into the office complaining of frequency and urgency and those bothersome nighttime symptoms. And so first thing we do is we always try them on a medication. And so that medication is, by the brand name, is called Flomax. I mentioned that earlier. And essentially what that does is it relaxes the opening of the bladder, allowing the patient to pee easier, allowing their flow to improve. And that can have, you also saw in the ad, the Urolift system doesn't have sexual side effects. That medication does have sexual side effects. One of those side effects is called retrograde ejaculation. So what does that mean? That's a big word, right? So essentially what that means is because the bladder is open, when you ejaculate, the ejaculate now has 2 ways to go. It can either go out through the penis or it can go back into the bladder. And so for some men, it goes back into the bladder, and so they don't see the product of their ejaculate. And it scares some men sometimes. And I tell them it's normal, it's just a side effect of the medication. They still experience the orgasm, just don't have the product.
And then when they go to the bathroom, it would come out.
That's right, they urinate it out later.
It out.
Yep, that's exactly right. And so with the UroLift system, essentially what it's meant to do is basically what it go into this area. Again, this is an outpatient procedure. It takes approximately 20 minutes to do. You go in, you're put to sleep. We go in, evaluate your prostate. We do all of that, the evaluation in the office before we even book a UroLift. It all depends on how big your prostate is and what your prostate looks like from the inside. And so there's 3 parts of a prostate. There's the bottom part, what we call the median lobe, and then you have the sides. You have the right side and you have the left side. And if they're all together, that's what's causing the obstruction of flow, that extra tissue. So what UroLift does is if you're under a certain amount of grams, that's prostate size, you go in with a camera, and what you do is you fire clips into the prostate, and it's a mechanical fix for a mechanical problem. So
His engineering.
There you
kits.
go.
that's right, that's what it
Engineering
is. That's exactly what it is. So you fire clips into the prostate. Once again, men, you are asleep at this time, you will not feel it. And
Good point. That's a good point.
Exactly. You fire the clip, and what it does is it actually pries open the tissue that's causing the obstruction. And that way, this channel that the urine flows through is much larger, so that theoretically should have a much better flow. Generally over, like, as the commercial stated, a period of 2 to 4 weeks, they have a much better flow. And the whole purpose of that is to get them off of the medication, the Flomax or any other medication that they're on. And this has no sexual side effects. That we were talking about earlier, the retrograde ejaculation does not happen with this.
So when you do this UroLift, that helps with the flow, but would it also help with the frequency? Because it helps get it all out, so they're not having to keep going.
That's exactly
Correct?
right. Yeah, so they're emptying their bladder more completely. There's not as much urine left in the bladder after they've done urinating. Again, the bladder now has to remodel itself to this new opening. You know, they'll say, "Doc, I feel like I'm 20 years old again, peeing," and so that's always a good thing to hear.
That is. That's
I have
great.
a question from a viewer.
Yeah.
Okay.
He says that he has all the symptoms of a kidney stone. He's had a CAT scan, does not show up. He has no infection, but he has all the symptoms and keeps having the symptoms of a kidney stone.
Okay, so to repeat that, someone called who said that he has been checked and does not have a kidney stone or has not been diagnosed as that, but has all the symptoms of them and keeps having the symptoms.
Okay, so he's had a CAT scan which was negative for a stone,
He said
which
no
did not,
stone.
right.
Didn't see a stone, but he's wondering if there could still be one.
It's possible, but if it hasn't been shown up on the CAT scan, it's unlikely to be a stone. A lot of times lower back pain or just musculoskeletal pain in general can present itself as kidney stones. I have patients come to me in the office thinking they have a kidney stone. We do the workup, we do the CAT scan, and we don't find a stone, much like yourself. And so what generally we do is I give them muscle relaxer for their back, because the difference between kidney stone pain and muscle pain is kidney stone pain does not get better with movement. It doesn't matter what position you're in, it does not get better. With muscle pain, there are positions that can make you more comfortable. So that's the key difference. So for this patient, based off of what he's telling me, it seems like it's more musculoskeletal, muscle in nature, than the kidney stone.
He's listening. So.
Okay?
Yep.
It would be important to follow back up, with your primary physician to evaluate.
Absolutely.
We need to talk about erectile dysfunction because I'm sure there are people listening who are sad because of that or have concerns about it. Can you help people with that?
Absolutely. So first thing I want to say about erectile dysfunction is it's nothing to be ashamed of. It happens to more men than you think. No one talks about it though, right? They talk about it with me in the office because I'm the urologist, but I don't want anyone to be ashamed of it. That's first and foremost. Secondly, it is absolutely treatable. Yes, it is treatable with medication, and it's also treatable with surgery. So first, let's talk about medication. There are medications I'm sure we've all heard of, Viagra, Cialis, that you can take that can help with the erections. A lot of times their primary care physicians will give them the Viagra or the Cialis, a prescription for it. But they'll come and see me in the office and say, "Doc, it's not working." A lot of times, I don't think people are generally instructed on how to take it. So this is how you take that medication. If you are given that medication, you're supposed to take it on an empty stomach and you're supposed to take it 1 hour before any planned sexual activity. Unfortunately, you can't be as spontaneous as you used to be with respect to that. You just have to have a little bit of planning, but that is generally how you take it. The reason being, it has better absorption in your body, and it gets in much faster, and it's more effective. The other thing about erectile dysfunction is there's many other things, controllable factors that can cause this. So smoking, for example. A lot of smokers have erectile dysfunction. The reason being, smoking can cause disease in your blood vessels, right? It can cause plaque buildup. Now, the vessels that go to your penis are small vessels. And so, imagine if you're smoking and you have plaque buildup in these small vessels, you're not going to have great blood flow there. And so, the first thing you have to do is stop smoking. You know, you have to stop that. You have to stop these habits that are causing these secondary symptoms. So that's one thing I always tell my patients, is like, no matter what I do, if you don't help yourself, I can't help you, right? So that's the first thing. The other factors that can cause erectile dysfunction, diabetes. Diabetes is very prevalent in this country, right? A lot of people have diabetes. And so same thing with diabetes. It affects the vessels. It causes plaque buildup and causes these things. Diabetics, you have to have your A1Cs well under control. That's the main thing. And that's generally done really well by the PCPs in this town. But if your A1C, if your glucose, your sugar is not well controlled, then no matter what I do for you, it won't be that effective. So if you're a great patient, which most of you guys are, so what can we do for you? So we can do the Viagra. We generally do it in a stepwise fashion. So we give them Viagra or Cialis, see if that works. And if they take it the way that they're supposed to take it and it's working, great. So I give them a medication for that. Now, let's say that stopped, it doesn't work. Or it has worked for a little bit, and now it's no longer working as well. And they haven't changed any of the other habits. So now what we'll do is we move on to an injectable therapy. It's called Trimix. That's what the name of the medication is. Essentially what it is, it's an injection that you go put directly into the penis, the shaft of the penis, and within a few minutes you should have an erection. And we do a demonstration whenever I prescribe it for a patient. I have them bring it into the office and I show them how to do it. Because you can't just inject anywhere on the penis. If you look at the penis like a clock face, you have a 12 o'clock, 3 o'clock, 6, and 9 o'clock. 12 o'clock you don't inject there because you have blood vessels and nerves that run there. At the 6 o'clock you don't inject there because you have the urethra, the tube that you pee out of, it runs through there. So the safe places are at 3 o'clock and 9 o'clock. And so I inject it there and I see what their response is. I give them half of a dose within the office. And I go see other patients. I come back and if they have a good response, I tell them you can take this much. Now the caveat to that medication is, I'm sure you guys hear it on commercials, if you have an erection lasting longer than 4 hours, that is an emergency. That is when you need to go to the ER. Call the office and go straight to the ER, we will see you there. And it can happen if you use too much of it. So just because a dose that I give you works well, does not mean you can double that dose. Right. All right? Because then you're going to end up in trouble, you're going to see me, and none of us are going to be happy about it. And that's another form of medication that you can use for erectile dysfunction. Let's say none of those things work. Now you're really at your last line. So now we can talk about prosthetics. We can talk about a device that we can surgically implant into the penis that allows you to get an erection. So what does that mean? So if you look at the penis is composed of 2 cylinders, hollow cylinders, that generally get engorged. It gets filled with blood. And when the penis gets filled with blood, you have the erection. But again, we talked about those blood vessels that are not working that well, right? So in this procedure, what we do is we make an incision where the penis meets your scrotum. We make an incision, we come down to those 2 cylinders. Basically, we hollow out those cylinders. And what we do is we put in an implant, which is basically a inflatable cylinder that goes into the penis. It is attached to a pump, and it is attached to something called a reservoir that holds fluid. So after we're good and done with the procedure, the way it works is the pump is in your scrotum and you can actually feel it. And so you just pump, whenever you're ready, you pump it up and it takes fluid from that reservoir and puts it into the inflatable cylinder. And then it gives you the erection. You do your activity. Once you're done, there's a button on the pump you press, and all of the fluid gets evacuated from the cylinder and goes back into the reservoir, and then you no longer have an erection. So again, a mechanical fix.
There you go. But you know, I think.
Yeah.
We have another.
Okay, did you want to finish what you're saying?
I was just going to say, I think it's important too for men to know that so many times they're taking medicines that actually the side effect of the medicine would be erectile dysfunction. So it's good to know that so that they don't stop taking a medicine that they need for a health problem, that they could reach out to you or one of your partners to get some help so that they can have good health, in addition have good activity as well.
And you encounter this a lot, so they don't need to be awkward coming and talking to you?
No, absolutely not. If you would like, I can make a joke to crack to break the ice.
Good.
Yeah.
We have a question from a viewer.
Okay.
They have erectile dysfunction. They take high blood pressure medicine.
Okay.
Could that be the reason?
So it depends on which medication.
Okay, well, let's say a person's taking high blood pressure medicine and wants to know if that affects erectile dysfunction.
Yeah, absolutely. So, I'm sorry, that's the question, yes. So it can. High blood, you always want to have your blood pressure controlled, generally speaking, but that can affect your erectile function. There's certain blood pressure medications, heart medications, that if they are taking, I cannot prescribe Viagra or Cialis for these patients. And that medication is called IMDUR, I-M-D-U-R. That's the brand name, because that can dangerously drop their blood pressure and it can be fatal. So for those patients, we have to take a different approach. And without going into further detail, I'd be glad to speak to them. Yeah, absolutely, in the office.
And y'all are located on Foy Drive?
Yeah, 180 Foy Drive. That's right.
Okay, and in 3 now, and you're getting another one this summer?
We're getting another one. It's going to be very exciting. We're all very excited, specifically because maybe you don't have to take calls much.
and your wife is moving here soon and going to be in primary care?
Yeah. Her name is Joanna Dauber. She's my fiance, to-be wife.
Okay.
We have 2 weddings. It's exhausting. We have the Hindu wedding in New Jersey, and then we have what I call the white wedding in Raleigh, which is the traditional wedding. And it's a lot of work. I mean, it is a lot of work. Yeah, she's going to be coming in. She's going to be joining the primary care group here.
Eastern North Carolina.
That's right, yeah. So she's going to be there, and what her focus, she's going to be doing, obviously, primary care, just all things involved with that. But her area of interest is actually women's health.
Oh, wonderful.
Oh, good.
Yeah, she loves that stuff. So that is what she would like to, she just wants to see more women.
There's a great need for that.
Absolutely.
In our area, for sure.
Yeah.
Do people need to have a referral to come and see you from their primary doctor?
I think certain people do, and most people do. Yeah, most people that I see are referred to me by the primary care doctor. But there are definitely self-referred patients as well. It all depends. So what I would encourage you guys to do there in the audience is, if you do have any kind of urological questions / needs, I would call your primary care doctor, see if you need a referral, and if you do, go ahead and get it for whatever reason you would be seeing myself or my partners for. And if you don't need a referral, come on in.
How do our wonderful hospital, Nash UNC, has cancer care, has women's care, has cardiology care. How have you found, since coming here, the support being, and do you find that most of the services, if you need to refer a partner, are right here?
Oh yeah, campus? I mean, it's quite wonderful because it's very collaborative. It's very easy to reach out to somebody, another colleague, another physician, say, hey, I have this patient here, I have a question, I think that this is what's going on, can we discuss it? And everyone's very open, and it's very easy to get them in. And because we're all one system, that is a huge help. Since we're all in the same network, I have someone in the office call, make them an appointment, done. And then that appointment date and time set that day that I need to refer them. That way, it's so much easier for the patients because they don't have to make it themselves, 1, right? And 2, I think that just that alone is a huge burden off of the patients. And 2, it's all in the same campus. It's 5 minutes away.
I think for a rural setting, a rural hospital, we are certainly vast in what we can do, and our relationship with the community is powerful. And so all we can do to serve the patients is what we want to do. So I think it's great that we have that oneness concept. So that's a great point.
I think it's been a huge help, and specifically with urology, I think we work very closely with the oncologists, the cancer doctors, and the radiation oncologists, specifically for prostate cancer. Every Friday we have something called a tumor board where we all meet together and discuss interesting cases, and it's very open, and we can all just, there's so many cases that we discuss, but there's suggestions left and right, and it's fantastic. Like I said before, it's a collaborative environment, and I think it just fosters better care for our patients.
That's a great note to end on.
Yeah.
We are so glad you're here. I remember when poor Dr. Pazak was really in need of more, but the thought that we have 3 and we're going to have even one more is just fantastic. So thank you for loving our community and for all you're doing for our hospital.
Well, thanks for having me. I really appreciate it.
Yes, thank you so much.
Well, thank you, and we appreciate you joining us. See you next week.
All right, take care.